So I am thrilled to have you all here. This is a real treat. It's a beautiful day here right at this moment. Sarah's in Idaho, so it may not have snowed there. But not only did it just snow, but the sun is coming out and it is so sparkly right now. It is just brilliant here in Winthrop. So it's pretty exciting time. We are talking today about palliative care, and we're really lucky in the Meadow to have a group of people who are trying to develop and strengthen palliative care awareness and services for all of us. And we have one of them here today with us, Justin Porter, who I will let introduce himself. And then I think what I'm going to ask each of you to do is to just say who you are and what brings you here. So do you want to start, Justin, about who you are and the work you're doing with palliative care and how you came to it?
Sure, yeah. So I'm really happy to be here because talking about this is one of my favorite things to talk about. It really is. So I'm looking forward. Every single time I talk about palliative care and healthcare in general, I feel like I learn a lot. And so this is one of my favorite subjects, is what I'm saying. I am a paramedic and an RN. And right now I work full-time as a paramedic in the Medhow Valley, Sarah. I'm at Arrow Medhow, who everyone else on this call probably knows what that is, and maybe you do, Sarah, but it's the EMS agency here. I also have a background as an RN, and I worked in home health and hospice here in Okanagan County as an RN. And those two worlds are really similar to me, believe it or not, being an RN in home health and hospice and being a paramedic. And I guess the difference is one has a lot more adrenaline and lights and sirens, but they're really similar and they boil down to some of the same things. So I came to palliative care from experiences in my work. I worked on a pediatric flight team in the Midwest, and we would fly in helicopters and planes all over the Midwest going and getting really sick kids. And I just noticed that something was off, something wasn't right about our healthcare system. These kids were going to have really poor outcomes. They were tremendously sick, and I could just see that there was a lack of communication, and there was a lack of patient and family-centered goals. So I knew when I left that flight team that I wanted to do something that was different, and I came by it through hospice and home health, and now I'm working trying to develop palliative care in Okanagan County. So I'm excited to hear from each of you, and I'm excited to be here.
Thanks, Justin, so much. We are really, the mindset of a palliative care person blended with emergency medicine is just such a gift to have in our community. So we're lucky. Why don't we go to Tracy? You want to?
Sure. Okay. Well, welcome, everybody. Thanks so much to Betsy and Justin for organizing this conversation today. And I am learning so much all the time as the new-ish, not brand new anymore. It's amazing how fast 9 months went by of Medhow at home. And I have kind of a holistic mindset around health, coming from a background in body work. And I've had a lot of experience being the spouse of someone who spent a lot of time in the medical system. And it makes a really big difference how holistic the approach is of the team that you're working with. And I really appreciate that we're having these conversations and about palliative care. And I've learned a lot just in this process of bringing this program to you all today. So welcome. It's great to be here.
Thanks, Tracy. I think I'm going to follow my screen, which may not be your screen at all, about who comes next. So there's not an order except that I'm following your pictures on my screen. Sarah, do you want to say a little bit about who you are and what brings you to this conversation?
Sure. I live in Moscow, Idaho, where it is not sparkly. We had storming, raining, and rain and snow all morning so far. I attended the earlier Zoom session that I think you led about end of life planning. Right? Is that?
Yes.
Yeah. So when I saw this one was coming along, I wanted to take it also to just increase my knowledge about that. And I'm not really sure exactly I have a vague idea what palliative care is. So I'm hoping to learn more.
You're our target audience. That's terrific. And then I particularly asked Michelle to join us. So Michelle, do you want to say a little bit about who you are and why you're here? Besides that I twisted your arm.
Well, I'm putting my arm back in joint. I'm Michelle Jerome. In the past, I have been home health, hospice, extended care, nursing home, rehab nursing. And I was in Whatcom County working for hospice when they started developing the palliative care team for the hospital there. And so the initial conversations for that came out of the hospice team. So I was in on that. I wasn't part of the team, but you know, it was around everywhere. And I've sort of been hanging out a bit with the palliative care team and other organizations in the Valley, but I don't really have active involvement anywhere in particular, except the advanced care planning. So that's me.
Thank you, Michelle. I apologize for looking at my phone there. One of our members didn't get an invite. So I will pass that information on to Tracy to correct.
Okay. I don't know if I can.
Thank you. Ellen, do you want to say a bit about who you are and what brings you here?
Sure. I guess I was just interested in the topic, partly because I took care of my brother for such a long time. And then when he left the hospital to go home to die, all of a sudden, all these palliative care people showed up. I presume the hospital must have told them, but there was really nothing for them to do. And it was, so I'm curious how that works. Thank you.
Okay. And Dave and Carlin, do you want to say a little bit about what brings you here?
There we go.
Okay.
You can have two voices. You don't have to just be one voice.
Well, Dave, why are you here?
Because you made me. Can you guys hear us now?
Yeah.
Okay, good.
I'm here because I have a degenerative disease that may end up requiring palliative care at some point. And I don't know if it'll be sooner or if it'll be later, but it's very likely that it is in my future. And I don't really understand exactly what it is, I have to admit. I think of it as comfort care. You know, sort of in that holistic sense that Tracy talks about, where it's not just physical comfort, but body and soul as well, or mind and soul as well. So that's why I'm here.
I'll say a welcome to Val Hecker, who just joined us, and ask Dave, do you have anything you want to add?
Not especially. I'm, basically here because Carlin is, I look after her, and so anything that affects her affects me, and vice versa to some extent. So I don't anticipate a need for palliative care anytime in my immediate future, but I would like to know about it so that I have a clue of what's going on when and if Carlin ever needs it.
Thank you. Adrian, do you want to say anything about what brings you here to this conversation?
Yeah, hi everybody. Thanks so much for doing this. I'm keeping my video off because I'm still during school hours and I might get interrupted by a school issue, but I didn't want to miss this just in case I could gather a little bit. Yes, my husband and I have been through end of life care with both of his parents. And my mom lives in Jamie's place, and I'm interested in helping her have a good phase of her life here. And so I don't know what that looks like in Jamie's place. I mean, being there in the first place is like a great step because that's a wonderful place and she's really happy, but I just want to make sure that I'm following through and we're sticking to the things that we think she would want in terms of having a happy end of life, possibly in the next couple of years. So, yeah.
Terrific. Thank you, Adrian.
Thank you. Thanks for doing this.
And welcome, Val. And I'm sorry to spring this on you. We've we've been going around the room, the Zoom room, just talking a little bit about what brings us to the conversation. And so would you like to share anything about what brings you here?
Absolutely. Yeah, my mom passed away in April after about 7.5 years of my dad taking care of her pretty much 24/7. And so now it's my dad, and I'm here to hear whatever I can about making that transition for him easier and having an idea of expectations and how to present those to him, just so it doesn't seem so daunting. And just to have a discussion about death and dying and how all that works and not being afraid of what he wants it to look like when it gets close. So yeah, any kind of information I can gather is helpful. So thank you for doing this, Justin and Matilda.
Terrific. So I think both, well, Justin and Michelle and Tracy and I would all very much like this to be a discussion. We have some questions to ask Justin to try to highlight a little bit about what palliative care is and what's happening here. But please, if you have things you want to ask or contribute, jump right in. You can do it through chat, or you can do it, I can probably ask Tracy to monitor the chat, or you can raise your hand, or you can just shout. The shouting doesn't work really well on this medium, but we'll try to respond. So I'm going to start with some questions, and then you guys can jump in. And I will start by just Justin, if you could talk a little bit about what's meant by palliative care and how it's different from primary care or hospice care.
Okay. Yeah. And I really encourage interaction here because I really just can't speak to a flat screen by myself. So please jump in and talk to me. And I heard some people knowing kind of what palliative care was and some maybe not. And that's really common. I just made a really, I thought, funny movie that I put on YouTube that's entitled Mysteries of the Universe, What is Palliative Care? And so I go around and I talk to people and ask them questions like, what killed the dinosaurs? And, what's in a black hole? And then I ask them, what is palliative care? And everyone I talk to, healthcare workers, lay people, family who I live with, don't know what it is. So it's really common. And one of the best answers that I got was that it's care for your palate. It's care for your mouth. So, so palliative care is a specialized kind of care for people with serious illness. Their illness can be symptomatic, but it doesn't necessarily have to be symptomatic. That's kind of like the textbook definition of palliative care. That's how CAPC, the Center for Advancement of Palliative Care, defines it: a specialized care for people with serious illness. So it's not hospice and it's not primary care. What distinguishes it from hospice is that in hospice, hospice is really just a Medicare designation that someone has 6 months or less to live in their life, to the physician's best guess. And all of their Medicare dollars are going to be going towards this hospice care. Hospice is performed in a team setting like palliative care. It's different. Palliative care is different from primary care because primary care is really not a team setting. So your primary care doctor could be providing you some palliative care services, but it's not the big picture palliative care and this sort of multidisciplinary approach. I think one of the things that, as I've grown in my role in palliative care and learned more about it, one of the things that I have come to see is that palliative care should really be usual care, that we should all, regardless of our illness or health status, have our healthcare providers providing a palliative care approach. And what palliative care is all about is communication. There is communication in palliative care like there isn't in any other form of healthcare, and that's why I love it. That's why I'm passionate about talking about it and learning about it and growing it here in Okanagan County. So I've brought a little movie for us to watch. It's just shy of 3 minutes. And I was going to explain the movie to everyone, but I think what would be more engaging would be that after we watch this movie, that we talk about it as a group. And what makes, I'll just tell you that there's a character named Bing Bong and he loses something. And there's two people that try to comfort him. And I want you to pay attention to how the different approaches are and how they try to comfort Bing Bong and how he responds. So if Tracy could show that movie, and it might take a second.
So we can.
Yeah.
The stuffed animal Hall of Fame. My rocket. Wait, Riley and I were still using that rocket. It still has some salt power left. Who's your friend who likes to play? No, you can't take my rocket to the top. Riley and I going to the moon. Riley can't be done with me.
Hey, it's gonna be okay. We can fix this. We just need to get back to headquarters. Which way to the train station?
I had a whole trip planned for us.
Hey, who's ticklish, huh? Here comes the tickle monster. Hey, Bing Bong, look at this. Oh, here's a fun game. You point to the train station and we all go there. Won't that be fun? Come on, let's go to the train station.
I'm sorry they took your rocket. They took something that you loved. It's gone forever.
Sadness. Don't make him feel worse.
Sorry.
It's all I had left of Riley.
I bet you and Riley had great adventures.
Oh, they were wonderful. Once we flew back in time. We had breakfast twice that day.
Sadness.
It sounds amazing. I bet Riley liked it.
Oh, she did. We were best friends.
Yeah, sad.
I'm okay now. Come on. The train station is this way.
How did you do that?
I don't know. He was sad, so I listened to what.
Hey! There's the train!
Oh, we made it! We're finally gonna get home! No, these facts and opinions look so similar.
Ah, don't worry about it. Happens all the time.
Could I get the 10-piece chicken McNuggets? Wait, no.
Okay, so instead of me talking about that video, I'd like to hear from you guys. What did you notice in the way the two different characters confronted and tried to comfort Bing Bong?
Well, one was trying to distract, the other one was actually listening.
Mm-hmm. Yeah, that's exactly right. And what else? So the two characters, the one that tried to distract is named Joy, and then the one that was comforting and listening is named Sadness. So what else about Sadness and Joy?
Joy was trying to take over, and it was sort of all about Joy.
Yeah. And anything else to add about Joy or Sadness?
Sadness put herself in Bing Bong's shoes.
Yeah, empathy.
Yeah.
Exactly. Another thing that I noticed, I've watched that clip probably a dozen times now. Another thing that I notice about Joy is that she actually gets annoyed by the emotion that's happening, right? She's like, what is going on? Why are you doing this? This is going to take forever. And I think we've all had those experiences where we've been with a healthcare provider and we need something and we're not feeling listened to. And inside them, they're thinking this is going to take forever if I go there. So, but when they walk away, Joy says to Sadness, how did you do that? And I can remember the first time I started learning some of these communication skills that are taught and learned in palliative care. People turned to me and said, how did you do that? That was great. It's not magic. It's, like I said, a skill that can be taught and learned. So in what I think distinguishes palliative care from all other forms of healthcare is that if you think about every kind of like specialty or discipline in healthcare, like an anesthesiologist, the primary procedure of the anesthesiologist is maybe to keep the patient pain-free through anesthesia during surgery and to protect the airway. Or a radiologist looks at images. So the primary procedure of palliative care is the family and patient meeting. So the skills of palliative care are really about communication. So we started talking about sort of the textbook definition of palliative care, which is palliative care is specialized care for people with serious illness. But really what it comes down to is that primary procedure of communication and the family meeting. Any questions about that before? Does palliative care feel understandable at this point, that it's not for your mouth, it's not for your palate?
I have a question, Adrian.
Yeah.
So, like, I just wonder if it's like the family meeting that you're talking to is like the meetings that Lookout Coalition has done, like Betsy, like we've had,
Yeah.
you know, with mom, or I had with Raleigh and Gordy's parents, that kind of meeting where we're just talking about the big picture, where we go from here, kind of. Okay.
Yeah, absolutely. I think that's what it would look like. if you were actually with a palliative care team as opposed to with, it's the same skills, it's the same thing. But yeah, absolutely. That it's about, I think we reflexively go through healthcare, and the providers reflexively go through their things that they do. And patients do it too. And palliative care is an opportunity to sort of say, stop, let's really talk about where we're going with this and make a plan based on what's important to you.
You mentioned the palliative care team, and I think that is kind of a core concept to the discipline. Can you tell us a little bit about how that works and what it brings to the dynamic or the interaction with a person?
So each discipline, it is sort of the core of palliative care. Each discipline brings to the table different strengths and limitations, and that's normal and that's okay. And when you bring multiple disciplines, you get multiple strengths and you shore up those limitations. So I'll give you two examples of how this might work. Let's say we have a patient who enjoys cooking, or maybe cooking with family or a grandchild. And one of the things they like to do is make chocolate chip cookies. I've actually seen this. This is something that I've witnessed as a nurse. Patient really likes to make chocolate chip cookies with family, but shortness of breath. They have such severe shortness of breath that making chocolate chip cookies is really hard. So me as a nurse and me as a paramedic, what would I do and what would a physician do? I think we'd be mostly thinking about the airway, the lungs. We might be thinking about the centers in the brain that sense that feeling of shortness of breath. So we would probably tell the patient to take a puff of your albuterol inhaler and maybe do a nebulizer, take your daily meds, and that would be kind of maybe the extent of it. If they're smoking, we might talk about smoking cessation. An occupational therapist is going to come at it from a totally different perspective. Occupational therapist is going to say, that stuff is all really important. Nothing wrong with that stuff. Absolutely take your inhaler. But let's look at how you interact with the activity of making chocolate chip cookies and see if you can still do it, if we can make some adaptations there. So the occupational therapist might ask the patient to, instead of standing at the counter and stirring with a wooden spoon in a big bowl, which causes exertion, the occupational therapist might instruct the patient to just go sit at the kitchen counter. Go sit down at a stool or at the table, at the kitchen table, and do it there. That way you're not standing and exerting yourself quite as much. The other thing that the occupational therapist might do is find or help you find or instruct you to use a stand-up mixer to make the chocolate chip cookies. So you can still do the activity, but you're making these adaptations that a nurse wouldn't think of. So that's one example. The other one I'll give you is pain. I think as an RN, if let's say a patient has neuropathic pain, so it's pain that has occurred because there's some sort of inflammation or damage to the nerves, and it causes shooting, burning, kind of electrical pain somewhere in their body. As a nurse, I might instruct the patient to take their anticonvulsant medication, which would be prescribed by their doctor to help with that pain. I might talk about heat or cold and see if any of those help. A music therapist could be involved with your palliative care team, and a music therapist is going to recognize sort of this thing that Tracy's talking about, is this holistic view of the patient and the pain, and see the pain as this biopsychosocial thing that needs to be addressed. It's not just a biological thing. So things like stress and anxiety can contribute to the pain. And so the music therapist might work with the patient to find songs that the patient can sing or listen to help bring down their anxiety and their stress. And that can be an adjunct to everything else that the patient is doing. So you can see by those two examples that this team is able to sort of come in at every angle and help the patient with whatever's ailing them in their serious illness.
Wow.
I'm curious how you see, I can imagine a team feeling overwhelming and confusing. Can you sort of explain a little bit about the actual mechanics of how this might work?
Yeah, I think you're right, Betsy. I think serious illness care is really confusing, especially living in a rural location like we do. It's just hard to keep track of everything and all the traveling that we have to do to manage our serious illness, right? At best, you're going to Wenatchee for a lot of your appointments. At worst, you're having to go to Seattle or Spokane. So it is confusing, and it can sound, it's really frequent when people have been through oncology or they've been through the ER a bunch, their primary care doctor, and they have other specialists for other ailments, that you're going to add something here. That just sounds like a deal breaker. I don't want any more. And that's really common. What palliative care can do for those people is become the hub that all of their other care can sort of focus off of. And that becomes the hub for them because goals are clarified here with the palliative care team. So every appointment isn't done reflexively. It's like, this fits in with my goals as the patient, as the family. And so it kind of clarifies everything. And my view is, and my experience has been, that it simplifies things. So it makes things less complicated and less confusing because goals are defined.
And where is the patient's voice in this conversation or in this process?
So it's going to vary based on culture. So some cultures, the patient is going to be by themselves and sort of a dictator about the whole thing, and that's absolutely appropriate. Other cultures, the patient doesn't want to be involved and the family's going to do it. You know, all those buzzwords that we hear about healthcare, particularly in politics, like patient-centered care and whole person care, they sound empty everywhere else except for in palliative care. It's too bad because it's so descriptive for when in the context and the setting of palliative care. But I think, just to sum it up, it depends on the patient's culture, but generally the patient is driving the ship. They are the boss of the care.
I find that pretty interesting because my mom had one appointment with palliative care. It was about a year before her death. And because she had dementia so bad, she didn't want her family speaking for her because she had always been a very person that was in control. And she wanted to speak for herself and not have others speak for her. But she didn't understand. And the team wasn't very clear about what palliative care was. And it was really difficult to get a description of what it was. And my mom kind of figured, oh, this is about end of life. I don't want to have anything to do with this. I'm not dying, and I don't want to talk about it.
Yeah.
So it really was not a very productive introduction to that kind of care. But I can definitely see the value in having something like that. I just know that having watched my mom, how difficult it is to work with elderly people who have issues with memory, who don't understand things anymore, and to get them to understand how palliative care works and how it can benefit them. I mean, I think that that would be a challenge for any team. So that's just
Yeah.
my 2 cents.
Yeah, thank you for sharing that. I think there's a couple things there. I think one of the things that we have to do a better job of is explaining what palliative care is. It is often involved with end of life care, but it does not have to be at all. So I think we need to do a better job of letting people know that just because they have palliative care doesn't mean like we're giving up on them or they're dying. And I think it turns a lot of people off, and hospice has this same thing. It turns a lot of people off because of the connotations with death. I think one of the things that we can do to improve on that is to have early advanced care planning so that when we get in those positions, we're comfortable with the topic of death and dying and serious illness. And also, if us young people have our advanced care planning done, it reduces the stigma for everyone who is closer. You know, we're all going to die, but it reduces the stigma so that everyone has it. So those are the 2 things that kind of come up in that, Val, for me. I wonder if
I might add something. I think you are so right on target that it can be difficult for a person with cognitive dysfunction to engage around their health goals. But one of the challenges and one of the things that I think palliative care teams are particularly skilled at is sort of helping someone articulate what's important to them about what makes a good day in their life. You know, what was important to your mother each day that gave her pleasure, and what could her healthcare team do to support that and support the people like you and your dad to make those things possible. So finding those things that will build some trust. I mean, maybe the most important thing to her was choosing her own clothes and getting dressed by herself, or you know, whatever. So how do you make that happen in a way that supports you and your dad while also helping her realize what's most important to her? And then also coming back to you and your dad and say, what is it about your lives that has been altered in this caregiving so that we can help you survive and flourish in this very difficult time. Michelle?
I'd like to add that there is sort of advanced care planning that for me, I have feelings about how I want to be treated should I have dementia. And right now, I don't particularly have dementia. And so I can put that in writing and have the discussion with my family. So that in the event I do start going down that path, then they know what's important to me and it doesn't hopefully become as much of an issue. So that type of thing is also available and can be pursued. I think there's some of those documents on the End of Life Washington website.
Yes.
Okay.
Ellen?
So this was another time, and at this point 10 years ago, but when I inquired about palliative care for my brother, who was a quadriplegic, by an accident, the hospital system seemed to say to me, well, then you going to give up all his other care. That wasn't exactly what they said, but they said you can't do both of this. So we were left, the most important thing for us at that time would have been this coordination of the bigger view, because we were left to take him to appointments, many different doctor's appointments, some of which proved quite detrimental and many of which were unnecessary. So again, this 10 years ago, different state, but someone should be able to get a palliative care team, and who evaluates that they can, and who initiates it? Their doctor?
Yeah. Yeah. Oftentimes their primary care doctor, or it could be someone in the hospital too that could initiate that. I think what we're getting at is a couple things that I think Val and Ellen are bringing up, which is that, number one, a lot of people, healthcare providers included, don't know what palliative care is. So Ellen, when you're told that your brother's got to give everything up, that's just not accurate. You know, someone just didn't understand. The other thing I think we're getting at is that palliative care services, in particular, in the community, in rural communities, are few and far between, because billing structures for palliative care just aren't there. So maybe we can talk about that later, but there just aren't robust palliative care services in sort of in the community, in the outpatient setting, really. So it makes it really hard. We're working on it. We're trying to make it better. Our team is.
Do you want to move on to that and talk a little bit about local palliative care resources?
Sure, that sounds good. So our team has funding there's 5 of us, and we are joined with 10 other organizations. We have 10 partners. There's 5 of us who have funding through Robert Wood Johnson Foundation, and we have a fellowship with them called Clinical Scholars. And so they pay us to learn and work on a wicked problem. And our wicked problem is that there is no palliative care in our frontier community. I would define, that's their term, wicked problem. And a wicked problem tends to be based on, what I've found about wicked problems is the more you look at them, the more questions you reveal. All you're doing is pulling back more and more layers of questions and no answers. And that's been the experience here. And part of the problem is that there's really not great billing structures. So palliative care resources here, there is one part-time palliative care nurse in all of Okanagan County. That's Sheila Brandenburg. And so she works closely with oncology in Wenatchee and sees patients on a part-time basis in Okanagan County. And she's also one of the clinical scholars, and she's also on another grant that our team has through HRSA, federal government. Other than that, we are, with this funding from Robert Wood Johnson Foundation and from HRSA, we are piloting a palliative care program. And it's not comprehensive, like the core, what's the word I'm looking for? The core of palliative care services is about a dozen things, from spiritual care to rehab therapies and so on. And we don't have the capacity. We want to be able to deliver that, but right now we don't have the capacity. So right now it's a pilot program where we work with specific pilot primary care doctors who refer patients that would benefit from a palliative care consult and maybe ongoing care. So that's really the gist of the services here and now. And hopefully it's getting better over time.
So the next question that does anyone have questions about that, about palliative care services here?
Well, you talked about grants here, but in general, how are they paid for? Medicare, Medicaid? private insurance?
Right. So one of the things that makes palliative care wonderful is what we've talked about, is the multidisciplinary approach. Unfortunately, billing structures only pay, Medicare will only pay physicians, nurse practitioners, and PAs to go and be able to bill for palliative care services in the community. That is also true for most private insurance companies too, since almost everyone does whatever Medicare does. In the hospital, there are inpatient palliative care services, but of course, there's always a physician or nurse practitioner in the hospital. So they're able to bill for that in there, in the hospital, in the inpatient setting. So it really limits, that means all the other disciplines which make palliative care so helpful for patients can't be reimbursed for their care out in the community.
So
Does that,
how do they
yeah.
get paid? Do you bill the patient?
No. So right now, for us, we're relying on, we're not billing the patient. Specifically with our team, we are using grant funding to pay for this, to see patients without billing them. Michelle, did you have something to add?
Oh, it's just I've heard other places developing foundations that do fundraising to help pay for the wraparound services they can't bill for. It's just a lot of creative fundraising has to go on for these very rich programs that are not reimbursable.
Yeah, I think of palliative care as a preventative kind of medicine. I know that's funny because it's in this like serious illness realm, but palliative care prevents so much potential suffering, and it decreases healthcare dollars spent. So I kind of think of it as preventative medicine, and our whole system is based on the incentive of, it's kind of based on how our system is about treating sick people, about people who need a lot of health care, not trying to prevent health care. And I think palliative care falls into that realm. And so it's just not favored. It's not paid for.
The other part I think is that as a team of people who provide care, that one of the key elements is having conversations between people on the team, and which help figure out what might be of benefit. And an individual occupational therapist could provide care and bill for that, but that conversation, that collaborative conversation, is never paid for. That's why people don't. I mean, if you're in a system like the Confluence system, which supports Sheila to do her work here, theoretically has a palliative care system, but it only can bill for individual work. It never can bill for that team conversation, which is so critical to really helping develop as Adrienne described it, she an IEP team for students. I mean, it just makes so much sense to get heads together to talk about a problem rather than have to do it in your silo or however you describe it. I'm going to go back. We were planning on making this an hour. If people can stay another 15 minutes, we can run over 15 minutes or so, but is that okay, Justin, with you? Okay. Yeah. And if anybody needs to leave, they should feel free. But what questions should a person ask themselves as they approach a chronic illness to help them make decisions?
I think there are two really important questions that people can ask themselves. And I think they're really at root the same question, but one is framed positively and one is kind of, I think, framed a little bit negatively. but I think they both get at the same thing. And what they're getting at is that as we encounter serious illness, the way we spend our time changes. And so I think the positive question on that is, what does a really good day look like to me? And how do I want to spend my time? And I think that starts a conversation. It starts a jumping off point for all sorts of discussions about goals of care and what the person wants out of their healthcare and out of their day. And when you have a discussion based on what does a good day look like for me, you're able to kind of like focus in rather than be scattered with all these different competing sort of desires and pressures. So it just focuses it. But the negative side of it, and I still think it's a wonderful question, is what is it that I fear most? And that too can jump off into a discussion about goals and what's important to the person. You get all sorts of interesting answers from both, but particularly from the fear one. There was a quote that I read yesterday. I'm reading a really good book, and there's a quote that I'm not going to get it right, but it's something like, language is the mother of thought, not the handmaiden. And I thought that was so nice, because when you're able to put your fears into words, you can sort of like gather them up and understand them a lot better, rather than them just being in your head bouncing around and not really sure of them. And once you can put some thought to it and some focus, you're able to sort of, you're able to guide your healthcare in a different way and the way you spend your day. So those are the two questions. How do I want to spend my time? What's what's a good day to me? And what is it that I fear most?
I'm going to see my dad on Monday. I'm going to ask him both those questions.
Yeah, it'd be interesting to the response you get. Yeah, I'd be interested to hear the response you get. I do think they're wonderful questions. And so if you see me around town, let me know.
Well, he broke his hip in August. So it's kind of compromised what he can and can't do. And he's getting a lot better, but I definitely know that question about what does a good day look like for you. You know, if he just gets one little thing done, probably that would make him happy.
Yeah.
But we'll see what he says.
And so I think that gives you a just sort of like a base, a foundation of information that when there's conflicts or questions about doing something or not doing something, you can say, Val, to your dad, well, Dad, 2 weeks ago, you told me that like starting a fire in the fireplace was the most important thing to you. And I don't know if that has, you know, what you're talking about now isn't going to help you do that. You understand what I'm saying? Like, you can kind of use it to sort of like guide decisions as you go. I think that if I could just offer a couple things that people can walk away with that are, I call them the superpowers of palliative care in my head, because I just think they're tremendous to use and they're really scalable throughout your life. And if you're going to have conversations like this with your family, there's a couple things that I want to offer. One is the use of reflective questions. I have found that anytime you start a sentence with these words, you know what you should do, you are guaranteed to not get them to do anything. You know what you should do, you should take out the trash. You know what you should do, they're not going to do it. People need to come to their own answers, and they come to those answers with your help through reflective questions. So the use of reflective questions is kind of just a superpower in these situations. The other thing that I would offer is the use of silence. Silence is really effective, and people who are offering the silence often feel really uncomfortable, but it's not uncomfortable for the person who it's being offered to, who is deep in thought. So that would be the other thing in these conversations that you can offer to someone. The last one are the 3 W's. I wish, I wonder, and I worry. And you can use those to sort of keep a conversation going. And I worry that if you don't walk with your walker, you're going to fall and really hurt your hip, as opposed to walk with your walker. You know what you should do? Just walk with your walker. Just do it. They're not going to do it. But when you express some emotion, I wish, or I worry, or I wonder, it tends to help the conversation keep going in a positive way.
Yeah.
I've got a question for you. At what point does someone with a chronic illness or a chronic disease, at what point should they be looking into palliative care?
I think it's tricky because you might not have a primary care physician who knows what palliative care is, or there may not be palliative care in your area. So if we're speaking generally, it's a tricky question. I think anyone with a serious illness would benefit from a palliative care consultation at a minimum. And then from there, you can decide with the palliative care provider and team whether or not ongoing palliative care services are needed.
Okay, define serious illness.
Yeah, good question. So it's what you would expect. It's what you would expect a serious illness to be. So people generally with cancer, chronic obstructive pulmonary disease, congestive heart failure, heart disease, dementia. It could also just be pain. So you could be a cancer patient who's in remission and you have leftover neuropathic pain in your hands. You're in remission. Your cancer has been, cured, and you still have pain. So you can still be a palliative care patient because that pain might be managed best by that palliative care team. So it's the things you would expect.
So it isn't necessarily terminal illness.
No, not at all. There is no terminal component to palliative care. And I hope that we will all walk away from this conversation, and I do a better job, and palliative care teams do a better job of explaining that to people. One of the things that makes palliative care distinct from hospice is there's no designation that the patient will die in 6 months or less. And also, in palliative care, you can still be receiving curative treatments. In hospice, you can't. So if you have cancer and you're on hospice, you can't have radiation or chemotherapy if it's to cure the cancer. On palliative care, you can both have palliative care and have that curative treatment. So there's no terminal component of palliative care. And once you have palliative care, you can come off it, or you can go back on it, or it can be with you for the rest of your life.
Thank you.
Yeah.
Yeah, I just wanted to chime in a little bit. Justin, when we were talking about this before, I thought that you brought forth an interesting point that any illness that affects the way that you live your life is a serious illness. You know?
I think that gets back to how you spend your time. And serious illness often affects how we spend our time. So I think that's probably a good way to think of it, is that it truly affects your life and affects the way you can interact with others and with your environment.
Yeah.
I'm going to suggest that I've got a question for the group as a whole. If anyone, including Justin, has a story about a time or a person or a family member where care went sideways because of a lack of conversation about goals of care, because goals of care weren't discussed. Michelle? I think you might be muted. There you
Yeah,
go.
I'm going to pick on my father. He developed a rapid growing lymphoma. It came from the lungs and it just spread rapidly in his lymph system. So he was going down quickly, and they were in rural Ohio. And the local oncology office had two oncologists. One of them happened to be black, one happened to be white. One of them was very clear about, this is where we are, this is the reality of the situation, these are the decisions you have to make. And the other guy, and how they were partners, we couldn't understand, but the other guy was more like, well, we're going to try this and we're going to see, and it'll probably work, and it usually does, and blah, blah. So my father loved that guy, and my mother liked the other guy. Meanwhile, my father was in significant pain. He was hospitalized. He was on hospice briefly, but that was back, oh my goodness, in the early 90s, and home treatment of pain was not perfected to the degree it is now. And so he ended up hospitalized. And so depending on the day, which oncologist checked in on him, his morphine, he required significant amounts of morphine, and he was getting really ditzy. And he never did deal with his goals of his life, of how he wanted to die. He was not dying until he died. And it was just really sad. The nurses would come in and he'd beg them to put bourbon in the IV bag instead of the morphine. It'd be cheaper and he'd like it better. And that was just the case. And my mother, she had us there, but she was left alone trying to manage this unmanageable situation. And it was very, very stressful. And it was probably one of the guiding things for me to go into hospice nursing, was seeing that kind of stress on a family without being able to have the conversation before it's too late. So I love picking on my father.
He deserves it. Anyone else? Sarah, do you have a story?
Well, I can only say that the first palliative doctor I met was caring for a friend who died, and it was very helpful. And we didn't even realize that the Lewiston Hospital had a palliative care doctor, and she came and she just helped with a lot. So my memory of it now is kind of fuzzy, but anyway, she offered everything that we wanted that his primary care physician wasn't in his job. So.
Carlin, do you have a story you want to share?
I really don't. I realized that I had no idea what palliative care really was. I think I was describing almost like hospice care when initially we were asked, what is it? What do you think it is? This is wonderful stuff. I've got a lot to think about. And I'm so grateful to you guys for putting this on. Justin, Betsy, all of you. This is just wonderful. And I'm so grateful. I had no idea. And I must say, I've got a pretty good palliative caregiver right here. But boy, it takes a toll on him. And it sounds like palliative care kind of addresses the whole family, not just the patient. And that's beautiful. So thank you to all of you. I really appreciate this. I'm very grateful.
Carlin,
Carlin,
I'm
you
really happy to see you here. I'm really glad you came.
Thank you. And it's nice to see your face after all our phone calls together.
Phone calls, yes.
Thank you, Michelle.
Carlin's raises the question of what to do in our area with where there's, you know, we all know people with need, and what is there for us here?
Yeah.
Thank you, Justin.
Yeah. Thank you.
So Justin, I have a question for you. What exactly is your title?
So at Aeromed How, I'm a paramedic.
Okay.
Yeah. So I'm kind of the lead paramedic at Aeromed How. Yeah, I don't know. I don't know. I don't really have a title in the palliative care. I mean, I try to bring EMS into palliative care is really my role. Yeah, I don't have a great answer. Sorry.
Well, you're on a palliative care team as a pilot, or as a pilot program. You're bringing it to this area. So your title and the other members of that team, what exactly is their title or position?
Okay, so we have, I'll just tell you about our team. So we have Sheila Brandenburg, who's an RN, and she works for Confluence, but she's also on our team. So she's funded through the HRSA grant and through Robert Wood Johnson Foundation. We also have Kevin Coffey, who is a nurse practitioner. And we have Raleigh Bowden, who's a physician. And we have Karen Jacobson, who is a behavioral health specialist. So that's our pilot team. Okay. And our capacity is really limited. This is one of those times where I would use one of those W's. I wish our capacity was greater. We are working on that. So we see right now our capacity, because with the exception of Raleigh, we all have jobs. I have a full-time job. So we see roughly three new patients per month. And then yeah, go ahead, Michelle.
If I developed a serious illness and I felt like I wanted a consult from the palliative care team, can I just call Aeromed How, or what do I do?
Yeah, I mean, since you've been on this Zoom call, of course you could, and we could make it move from there. The normal way that it works is by one of our pilot PCPs who has agreed to do this identifies one of their patients who would benefit from palliative care, and then a lot of the local providers just know that we're out here doing this, so they might call one of us and say, "Hey, are you guys doing palliative care? Or can we get our patient in with you right now?"
So I could ask my doctor.
You could, yeah.
Okay.
And Justin, if you are in the Confluence system, then it would be Sheila who would coordinate that?
Yeah, exactly. So Sheila would be able to make either a telehealth or in-person visit with someone. Yeah.
Great.
Yeah.
There is hope that the program will be able to continue and expand. Is that correct, Justin?
Yep. Yeah, one of our main yeah, one of our main focuses is sustainability and trying to look for funding, look for ways to bill and to sustain this and grow it.
Great.
Okay, well, any last questions or concerns, or stories to bring up, or? We're so grateful to all of you for